Now, what is a distal radial ulnar joint? Like what the terminology says, it is a distal part, radius and ulna, where it articulates, right? This is a diarthrodial joint. There is a limited osseous constraint in the sense, the anatomy per se of these two bones, there won't be any constraint. It is not like something like say a hip joint, where by default of the structure, the femoral head can stay within the acetabulum. No, here there is absolutely no inherent stability. Everything has to be provided by other elements. Okay, so the stability is provided by certain things. All of these combined, you could call it as TFCC. Okay, triangular fibrocartilaginous complex. Now, mind you, triangular fibrocartilaginous complex is a little different entity than triangular fibrocartilage. Okay, we'll come to that as we go through the slides. But these two are different entities per se. Okay, so it's not the same. So don't get confused. So this is the bony anatomy that we're talking of. Now, if you look at, say, an axial cut of a distal radius, or in real life, in anatomy of a distal radius, the sigmoid is not really congruent with the distal part of the ulnar head. Okay, so in most cases, in 40% of the patients, sigmoid is actually flat. So sigmoid is flat shaped, and we have a rounded ulnar head. So we can also have a ski slope, that is, it is convex and then concave, or flat, that is ski slope. We can have a C type. This is what we presume things are, but in most cases it is not. Most cases it is flat. And then we can also have an S type. Okay, so that's how different it could be. And hence, the recommendation is that if you want to treat it, then get opposite side X-rays and CTs also, so that you know what you are dealing with and you can try to match your post-surgical result to that particular type. Okay, so this is called the Tollard categorization of how you categorize the sigmoid notch. And we have these four types: the flat face type, the ski slope type, the C type, and the S type. And which the flat face is the commonest one amongst these four, right? So the bony elements per se do not have much of an inherent stability. So we need to have some stabilizers. And what are those stabilizers? The stabilizers put in the entire complex is TFCC. That is a fibrocartilaginous complex. Okay. So these are made up of what all things? These are made up of superficial dorsal and volar radioulnar ligaments. So the radioulnar ligaments that we see, this is the superficial and deep. So volar, this is the dorsal, as well as the volar, similar things. Okay. So these are very critical ligaments. And then we have the fibrocartilage proper. Okay, so the fibrocartilage proper is also called the articular disc. So some of the articles, some of the books may give it as articular disc, so do not get confused. So that is the disc proper. Okay, and all these elements put together is the TFCC. Okay, then we have the ulnocarpal meniscus. Then we have the extensor carpi ulnaris, the sheet of that, which is very close to the styloid. And then we have the ulnocarpal ligaments, which are those. This is the ulnolunate and the ulnotriquetral. Okay. So this entire thing, these six different things in combination is called the TFCC, triangular fibrocartilage complex. Okay. And the injuries amongst this are also very common. So these stabilize the distal radial ulnar joint per se. Couple of things over here. Anything, if it is damaged in isolation, it cannot cause instability. In the sense, if any of these structures, a single structure is injured, it cannot cause instability of the distal radial ulnar joint. So the moment we have a distal radial ulnar joint instability, you have to automatically understand that at least two, if not more than two elements of these are damaged. Okay. So clinical examination, it's vague, but all of them, like I told, are you are trying to focus on a particular region rather than a particular entity. Okay, there is point tenderness over distal radial ulnar joint. Again, depends on whether it's an acute presentation or a chronic presentation. You can do the anterior and posterior draw test, the ballotment test. So you get a clunk feel whenever we try to move the joint, and then with wrist rotations, it is painful in most cases, right? So this is how you try to understand that there is some issue with this distal radial ulnar joint per se, or the triangular fibrocartilage complex, the TFCC, one among these two. Okay. What are the imaging that we do? The X-rays, the standard PA oblique lateral views helps us, especially if there are fractures of distal radius or ulnar styloid. It helps us to know what all bony elements are injured. And of course, in the lateral view, we can make out if there is a subluxation of the distal part of the ulna, volarly or dorsally. It's mostly dorsal, but even it can go volar. So these are the elements that we look for. Again, if you are contemplating to surgically manage, get an opposite side also in the similar view so that we could match it. In the CT, there are multiple things that we look into. We look into the type of sigmoid. Like I told, there are 4 types, and we want to know what type this particular patient has. Then you look into how the distal part of the ulna is articulating with that. Again, there are multiple methods of trying to understand the congruence between the sigmoid and the distal part of ulna. So this is the congruence method where you draw an arc on the sigmoid notch and the arc of the ulnar head and try to see if it's congruent. But this really doesn't give us a very true picture because in most of the cases, on the volar side, we see a little lesser gap compared to the dorsal. Again, it is dependent on the patient. It is not very specific. Okay. MRI is reserved to those in whom the TFCC injuries are presumed. Otherwise, if it's only bony, MRI will not help us much. So these are actually for theory exams that you write X-ray, CT, and MRI. There are the CT also very peculiarly, unlike almost all other injuries in the body, we need to get CT in different position of the limb, right? So, for example, look into this patient. When you get a CT on the neutral, the distal RadioUlnar joint looks to be well congruent with the sigmoid. The same thing in supination also seems to be fine, but when we take the same patient CT on a complete pronation, then we realize that there is a dorsal subluxation of the distal part of the ulna. So, and it is not necessary that it is only in pronation. Sometimes it could also be in supination. So the recommendation now is if you're getting a CT and if you're contemplating surgery, we need to get CT neutral, complete supination, as well as complete pronation. And of course, get parallel view of the opposite limb also in the same position so that you could compare, right? So this is how definite injuries like these could be missed if you get the CT maybe neutral or on the opposite side supination. Okay, so it is much recommended to get in all 3 planes. There are other modalities also. Ultrasound is a way to look into it, but it is significantly user dependent, especially the lesions with respect to the extensor carpi ulnaris tendon could be well appreciated. The tenosynovitis and all could be well appreciated, right? Arthrogram is a great technique to understand. Now, in many of the places where MRIs are not available or because of the cost constraints, it is much easier line of investigation and much cost effective. All you need to do is inject a dye within the capsule of the wrist. And if there is a leak of the dye on the ulnar side, we know that there is some damage to the TFCC, one of the parts of the TFCC. That's how we interpret arthrogram. Arthroscopy is also a very definitive way of finding out what it is, but the only thing is it becomes an invasive procedure. So if you are going in for an arthroscope, we need to be prepared for even the repair or the reconstruction, depending on whether the patient is acute or a chronic presentation. So these are the different ways of how we can diagnose, rather evaluate a distal RadioUlnar joint and the TFCC complex. Okay. So there are classifications to these. The easier one is the Palmer's classification. It is divided into 2 types. Class 1 is traumatic and class 2 is degenerative. In class 1, again, it is 1A, 1B, 1C, 1D. Similarly, class 2, which is degenerative, it is 2A, 2B, 2C, 2D. It's very easy, and this is a very easily reproducible one even in your exams. So type 1 will be a central tear on the disc per se. 1B is an avulsion on the ulnar side, 1C avulsion on the carpal side, and 1D avulsion on the radial side. So ulnar side, carpal side, and radial side. So you can remember it like an arc of injury. So that's 1A, 1B, 1C, 1D. And type 2, which is the degenerative type, we again have A, B, C, D. In A, it is mostly thinned or frayed out. In type 2, there is a wear and similar to 2A, but with lunate equatorial ulnar chondrosis. In type 2C, it is without chondrosis. In 2D, there is ligamentous perforations, and 2E is any of the above with an ulnocarpal arthritis. That is a very long-standing thing where the ulnocarpal joint is going to an arthritis, right? So this is the different patterns, and again a very easily reproducible one. There is one more classification system which is slightly difficult for you to reproduce in your exam. That's the ADSI classification. This is the very often quoted classification. So this takes into account everything, in the sense it takes into account clinical findings, it takes into account your arthroscopic findings, radiographic findings, and also tells us certain line of treatment regarding how we need to do. So this is divided into class 0 to 5. In class 0, of course, everything is near normal, and all it required to do is splint it. In class 1, clinically, you will class 1 to class 4, clinically you will have mild laxity, and class 5 there will be a variable laxity. Okay, so what about arthroscopic findings? The appearance of TFCC looks normal in class 0. There is a peripheral tear in class 1 and no tear in class 2 and 3. Class 4, it's massive tears. Again, class 5 everything is variable other than finding an osteoarthrosis. Okay. And radiographic findings, again, could have an ulnar styloid fracture at the most in class 0. We can have isolated tears in class 1, tears of both the distal as well as the proximal components in class 2. But more critically, what is important is how do you treat this? So, as we understand, class 0, almost everything is normal at the most ulnar styloid fracture. Splinting is more than enough. If there is a tear in the TFCC, it requires suturing. Now, this is acute, mind you. And if from class, so it requires a reconstruction. We'll come to this a little later of what are the different management that we have. Whereas if we have something of osteoarthrosis, it requires certain salvage procedures. Okay, so this is EDSIS classification, a little difficult to reproduce, but I'm pretty sure at least 50-60% of this, if you're able to reproduce in your exams, it should be good enough. Okay, so how do you treat? Now, this is where, like I told, different literature has different lines of management. Don't bother too much into thinking too much in depth. In broader terms, you divide these injuries whether they're acute or whether they're chronic. If they're acute, then again, whether the acute injury is with a distal radius fracture or without a distal radius fracture. Most literature agree on the fact that the moment you have a distal radius fracture, you do not need to do anything to the ulnar side, right? So you need to get the distal radius fracture back to its anatomical reduction and a stable fixation. That's all that is required. Once we do that, because these are all soft tissues in and around the joint, they are tensioned to its normal structure, and then they heal in that position, and hence the patient should not have a chronic disability. That's the basic understanding whenever you have a fracture. Okay. So no matter what level the ulnar styloid fracture is, because again it is debated whether if the tip there is a fracture we need to treat differently, there's a base is a fracture we need to treat differently. No, if we have a distal radius fracture along with any other injury which is pointing us towards the distal radioulnar joint or the TFCC, we don't need to take care of it. Only distal radius fixation is enough, right? So whether the ulnar styloid fracture heals or not has no impact on DRG instability. And like I told, an isolated tear in TFCC will not cause an instability of the DRUJ. Okay, so it has to be included in 2 or more pieces, which is very unlikely when you have a distal radius fracture. That is, if there's a distal radius fracture. What about dislocations or instability of distal radioulnar joint when there is no distal radius fracture? So if it's an acute injury, we need to attempt close reduction. After reduction, if the DRUJ is stable, we need to immobilize it for 6 weeks. Again, literature is equivocal whether we need to put on a cast or whether we want to put on a splint. But what we need to remember is that we need to prevent pronation supination. We need to prevent patient doing pronation supination in these 6 weeks. So ideally, above elbow cast is what would be required, because below elbow cast will not be able to prevent this. And if the patient pronates supinate, again, the reduction may be lost, right? So if the reduction, you are able to achieve the reduction, but it's very unstable, then obviously we need to hold the reduction with a pin, with a K wire. And what position do we do that? It depends on in what position is it the most stable. So once you reduce it, take it through a complete arc of pronation and supination. Most of the DRJ are stable in supination, so we need to maybe pin it in supination. But if that particular patient that you're treating is stable in pronation but not stable in supination, then you have to do a pin it in pronation also. Okay. So in whichever arc it is more stable, or in whichever arc it falls back easily, in the same position, we need to pin it. So that's how we do. If you are not able to achieve the reduction because with closed maneuvers in acute, mind you, that means there is some interposition of something there which is preventing us from putting the joint back into its position. So in those scenarios, we need to do an open reduction. So again, depends on whether the DRUJs, the distal ulna is gone volar or distal ulna is gone dorsal. In most cases, it goes dorsal, so we will require a dorsal approach. But if it is gone volar, we need to take a medial volar approach to take care of the any structure that might have hindered the reduction. Okay. For chronic injuries, again, there are multiple methods. From theory perspective, you can just highlight or headline what all methods we have. The simplest one is capsular application. We have pronator quadratus advancement. So what is done is the pronator quadratus attachment on the ulnar side. It is distalized and made it a little more dorsal so that it gives us slight restraint to the distal RadioUlnar joint. And various methods of TFCC reconstruction. The commonest or the most quoted about reconstruction is the Adams reconstruction, where a palmaris longus tendon is taken through the radius, taken through the base at the near the ulnar solet, and held on with a suture anchor. So this is what is considered as the anatomical reconstruction. There are other non-anatomical methods, especially tenodesis, where the ECU, which I told you was lying in close proximity, could be used, and tenodase to give some restraint to the distal RadioUlnar joints, right? And in type E, or the worser types of injuries, especially the long-standing ones where the wrist joint or the ulnocarpal joint is already gone into arthritis, then of course we need to do some salvage procedures. The salvage procedures are same what we discussed a couple of weeks back in distal radius malunions. We do a DRAC or a Saukapanji. The DRAC is where the entire distal ulna is resected. That is mostly not done now. What is done is a Saukapanji procedure where a pseudo joint is created. A distal, the ulna is resected. The distalmost part is left in place. The distal metaphyseal part of the ulna is resected, and the distalmost part is pinned across, or a screw is put across. And this particular part where we have resected, it acts like a pseudo joint, right? Constrained arthroplasty is also done. We'll find a lot of these in literature and in textbooks, but it's not a common procedure done in India.